Good morning, ladies and gentlemen. Dr. Granda has given me the hard task of answering this question: has the controversy been put to rest about sodium and heart failure? I have no disclosures. So in case you didn't think this was a timely discussion, on April 6th, in the Washington Post, which is one of the premier newspapers in our country, there was this article saying more scientists doubt salt is as bad for you as the government says. And it points out that even the American Heart Association has its members that can't decide. So the current president, Elliot Antman, said everyone agrees that current sodium intake is too high. And later in the article, they say a former president of the American Heart Association, Suzanne Operl, says the current salt guidelines are based on almost nothing. And that really is the status of maybe not so much salt in general, but certainly salt in patients with heart failure. We heard a lot yesterday about the controversies around salt and cardiovascular disease and salt and hypertension. But in case you thought that it hasn't really been embraced, the World Health Organization likewise has guidelines for daily sodium intake, so that they're suggesting that adults should be under 2 grams and children under 2 grams. And they suggest that there are no adverse effects on blood lipids, catecholamines, or renal function. And we also saw this yesterday, that they calculate that the absolute and relative mortality attributable to sodium is extremely high. Now, more relevant to heart failure is this study that looks at the genes that are upregulated in a patient who's eating excessive salt. And in particular, at the higher levels of sodium, genes that target inflammation and therefore autoimmune diseases are upregulated, suggesting that sodium has a plethora of downstream effects that we don't yet understand. And again, we saw this yesterday, that in totality, if you measure sodium excretion, the incidence of cardiovascular disease goes up. Even Professor Salim Youssef, who has been a strong proponent that sodium limitations do not have to be so strict, shows in this paper that in patients who have hypertension, increasing salt is much more important. In other words, for normal people, sodium restriction may not result in disease, but in patients who already have cardiovascular disease, in this case hypertension, sodium becomes much more important. And I would submit to you that that's very relevant to the field of heart failure. So that just like in hypertension, if somebody has heart failure, which is a salt-avid state, that sodium restriction is probably more important, even as shown in this slide. And in this same paper, Dr. Youssef says the problem is the absence of large randomized controlled trials. Pending such trials, even he suggested current evidence would suggest a recommendation for moderate sodium intake in the general population of 3 to 5 grams per day, targeting the lower end of the moderate range among those with hypertension. We could replace that with heart failure. Nevertheless, when the American Heart Association and the American College of Cardiology got together to write the lifestyle management guidelines, here's what they said. There's a very good level of evidence, and the strength of the evidence was high about the overall effect of dietary intake on sodium on blood pressure. But if you jump down to here, what is the effect of dietary intake of sodium on cardiovascular disease outcomes? This looks at all cardiovascular disease events, strength of evidence low, greater risk of fatal and non-fatal stroke, strength of evidence low. How about the evidence to determine the association between sodium intake and the development of heart failure? Insufficient evidence. I probably don't need to go on because that really sums up where we are. But let me show you a few more things. Other guidelines, including the ACC-AHA guideline for the management of heart failure, said sodium restriction is reasonable for patients with symptomatic heart failure to reduce congestive symptoms. Level of evidence C, Class 2A, not a very strong recommendation. And the European Society of Cardiology doesn't even mention it until way down in the section 15, and it says salt restriction. Is it effective and safe? That's the end of the discussion. So what we know for certain in heart failure is that the activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system causes salt and water retention despite fluid overload. We all know that. Natriuretic peptides are inadequate to overcome fluid overload in symptomatic heart failure. Dietary sodium restriction is associated with further neurohormonal activation in heart failure. That's certain. Clinical studies assessing the effect of sodium restriction on outcomes in heart failure are extremely limited, and sodium intake is very challenging to measure, which further compounds the problem. So all of us as clinicians know from personal experience that patients that take in too much salt can cause decompensated heart failure. This is an old study in 2008 from the Optimize HF registry that looks at factors associated not only mortality rates by precipitating heart failure and non-adherence to diet and non-adherence to medications is important. And if we look at the multivariate risk-adjusted in-hospital clinical outcomes, non-adherence to diet is important, not as important as other factors. But we know that. We didn't need a study to tell us. We've seen it with our own eyes as patients come into the hospital having eaten too many American pizzas and Chinese food and soup. And there are some other studies looking that a high sodium diet is associated with acute decompensated heart failure. These are studies from Arkan that Dr. Costanza was kind enough to share this slide with me, looking at the level of sodium intake in acute decompensated heart failure and sodium intake and mortality. Likewise, both in the United States and Korea, there's a relationship between the amount of sodium intake and in particular measured by urinary sodium, which most experts agree is really the only way to assess sodium intake, that lower sodium produces better outcomes. But then we have data, which I'm sorry to say comes from Italy. And this was a very controversial trial that took a small number of patients, gave them an inexplicable high dose of diuretics, furosemide at 250 to 500 milligrams of furosemide intravenously twice a day. I've never used that much furosemide. They gave it to patients and stabilized them and randomized them, restricting their fluid as well. And in this arm, they restricted them to very low sodium. This was a more normal sodium. They continued the furosemide at this unbelievably high dose and showed that the patients on a regular sodium versus a very low sodium did better, and that the BNP was less upregulated. The problem, and this created a huge firestorm proving that restricting sodium was bad. And this group published several papers saying the same thing. My moderator is helping me give my talk here. So what I was going to add is subsequently some of this data has been retracted. So I think we could all agree that there is data on one side to the other saying we could make a good argument for restricting sodium, we could make a good argument for not restricting sodium. And this is shown in this somewhat complex data slide showing low sodium intake decreases the need for diuretics, decreases filling pressures, decreasing congestion. All of this is good. On the other hand, on this side of the graph, low sodium intake causes decreased renal perfusion, decreased cardiac output. I could argue either side. And in fact, in this paper, of which I'm an author, we concluded there is insufficient data to endorse any specific level of sodium intake with certainty, and differences among the various heart failure subpopulations are not known. So what we really need is really good trials. This one was recently published that looks at the DASH diet, which is the dietary approaches to stop hypertension in patients after acute decompensated heart failure. They're calling it the Gourmet Heart Failure Trial. They're taking patients over 65 years of age with hypertension and acute decompensated heart failure and providing low sodium meals in the form of the DASH diet versus dietary advice, and they'll follow them along. It's only being followed for 12 weeks. And we can see that that may give us a little hint, probably a more normal circumstance than giving 500 milligrams intravenously twice a day of furosemide. But I would point out finally this schema, which looks at the problem we have of controlled trials. So if we go from ideal health to risk factors to clinical disease, you can do randomized clinical trials taking patients that are normal or have risk factors such as hypertension or coronary disease, or actually have heart failure, and we can follow them for a short period of time, and that is something we're used to. But if we're really going to answer the question about reducing sodium in our diets and preventing heart failure, we have to either do an epidemiologic observational study following patients all the way through from normal to risk factor to clinical disease, or we need to take a free living cohort and randomize them early on and follow them forever. That's not so easy to do. They have done this in other populations looking at lipids, but these are what will have to be done to answer these questions sufficiently. In the meantime, I would say to Dr. Granda and all of you, has the controversy been put to rest? There's a big no. But I would suggest, while we're waiting for very difficult to acquire randomized data, I'd suggest humbly my own recommendations, and that is in patients with marked volume overload as inpatients, overall nutrition is probably the most important thing to address. For outpatients with high diuretic need, moderate salt restriction makes sense. And for the rest of us in developed countries, low sodium diets save lives. Thank you very much.